Thanks for joining us today for a very special presentation. As you know, it's a priority for Kansas City University to become a more diverse, equitable, and inclusive campus. 2 years ago, we looked at ourselves through a pretty deep and transparent process. The campus climate study identified areas of greatest challenge for us. Through our Office of Diversity and Inclusion and Dr. Ken Durgan's leadership, we've begun a number of new initiatives in support of our goals of addressing many of those challenges. Critical to our success will be a foundational understanding of the sources of health disparity, our responsibility as educators of health professionals to be an important part of the solution, and the kinds of changes that we as an organization need to make in order to establish not only an inclusive campus, but one that ascribes to an anti-racist culture, a culture that works towards addressing population health issues for all the communities that we serve. Here today to talk about these issues and a lot more is Dr. Barbara Ross Lee. Dr. Ross Lee is a nationally recognized expert on health policy and serves as an advisor for state and federal governments on primary care, medical education, and healthcare issues that affect minorities, women, and rural populations throughout this country. Dr. Ross Lee has served as director of the American Osteopathic Association Health Policy Fellowship Program, the training in policy studies for postgraduate osteopathic trainees. It's also called the TIPS program, and the Institute for National Health Policy and Research. Dr. Ross Lee is also a member of the executive committee of the National Osteopathic Medical Association. She was the first African-American woman to serve as a dean of a United States medical school, serving Ohio University's Heritage College of Osteopathic Medicine from 1993 to 2001. And she was also the first osteopathic physician to participate in the Robert Wood Johnson Health Policy Fellowship Program through the National Academy of Medicine. And actually, that's how I met Barbara, because I was the second osteopathic physician and also the last osteopathic physician to serve in that capacity. But I tell you that experience was one that shaped my career, and I know it had a very positive impact on Barbara as well. Dr. Ross Lee hails from Detroit. She's the eldest of 6 kids, including her sister, the famed singer Diana Ross. She earned a Bachelor of Science degree in biology and chemistry from Wayne State University in Detroit, and a Doctor of Osteopathic Medicine degree from Michigan State University. Barbara was my first commencement speaker when I became president at Kansas City University. She is someone that tells a profound story. Her work has been impactful for the osteopathic profession and the overall organized medicine in general. She has shaped policy at the federal and state level for decades now. Please join me in welcoming really a true leader in academic medicine, my friend, Dr. Barbara Ross Lee. Barbara.
Wow. Thank you so much, Mark. So I'm pleased to be back at KCUMB, and I want to thank President Hahn and Associate Provost Durgans for this invitation to speak to you. And speaking to you at this very pivotal time in our nation when we are experiencing social justice unrest, a pandemic, and economic instability. I would also like to extend a special thank you to Martha Lawrence for all of the information and assistance that she provided me. And thanks to all of the attendees for their willingness to be a part of what I hope will be an ongoing discussion. Whenever I speak, I set objectives for myself. My objectives today, and today I have 3 objectives. My objectives today are to first be informative, maybe tell you something you didn't already know. Second, to be provocative, so that you may view issues different and circumstances differently. And finally, to be engaging, to motivate you to ask questions so that I can learn from you at the end of this presentation. So the title of my presentation is The High Ground, Medical Education and Health Disparities. All of my comments can be extended to other health professionals as well. But this topic requires a context. So let me start by giving you healthcare facts from the high ground as a context. First, pre-COVID, the American healthcare system has been described as being in crisis for decades. That crisis is described in terms of access, cost, and quality. All 3 documented to have a disproportionately negative impact on minorities. Second, pre-COVID, the identified social determinants of health, which include environment, education, housing, employment, type of employment, race, and access to health care. The determinants outline the systemic societal contributions to health disparities and acknowledges racism in all of its forms, explicit, systemic, and implicit, as a driver of minority health disparities. Pre-COVID, the economic and financing model of the US healthcare system is not aligned with the health needs of the total population and creates underserved populations based on their personal economic status. Another pre-COVID fact, there are persistent shortages and maldistributions of the healthcare workforce without a national healthcare workforce plan. And pre-COVID, changing population demographics. And I stress this, changing population demographics, where white non-Hispanics represent 56% of the US population. And a combination of Black, Hispanic, Asian, Pacific Islanders, Native American, Alaskan Natives make up a combined 44%. And that 44%, by the way, has a birth rate higher than the current majority. So we expect a transition where sometime in the relatively near future, the minorities will become the majority. Now, today, the movement for social justice has shined a light on the systemic racism and implicit bias that exist in our society. And for healthcare, it is well documented and long studied. COVID-19 pandemic is not just something we get through. It has changed and will continue to change the landscape of the healthcare industry, including medical education going forward. We're already seeing some of these changes. We're seeing hospital closures, rising unemployment, and declining health insurance. closure of small businesses, declining job growth, and we're facing current legal challenges to the continued coverage of pre-existing conditions. It's interesting when you have over 7 million people who now have a pre-existing condition based on a positive COVID test. And that's just the ones who were tested. Not as yet known are the long-term consequences of a COVID infection, specifically involving the vascular system, the central nervous system, and the heart. We also know, at least short term, that physician income has taken a dip. More so, Medicaid support, because of the state circumstances in fighting COVID, Medicaid support will probably, for a graduate medical education, will probably be impacted in a negative fashion, possibly even Medicare. So we continue social isolation, physical distancing, quarantine, wearing a mask, and hand washing for at least another year, maybe two, dependent on vaccine availability and efficacy. We're also seeing, and this is definitely something I know you all have been actively involved in, and that is less active and in-person learning. We're using more passive learning methodology, especially utilizing the available technology. The post-COVID economic recovery is projected to be at least 10 to 12 years in the future. And that's once we get the vaccine. Based on the increased disease burden produced by COVID, more minority patients will be in the healthcare system going forward. That's the context. So now let's talk about what we all do, and that's medical education. First, what are the expectations of medical education? Well, most of the expectations come from the public. The public expects medical schools to produce physicians who are competent, caring, compassionate, good communicators, honest, unbiased, and trustworthy. The state and federal government support this public expectation through licensure and support for graduate medical education and financial aid for medical students. The medical school has a responsibility to select the next generation of physicians and to provide the fundamental and foundational education to competently deliver the full scope of fundamental clinical care that addresses population health needs. That's our responsibility. We have a responsibility to develop and deliver an academic curriculum that will prepare physicians to support health and treat disease of the populations and communities that we serve. We have the responsibility to instill and develop professionalism in all graduates as defined by the AOA's Code of Ethics. The profession supports this responsibility by establishing accreditation standards for medical education to produce physicians who are competent as measured by the knowledge and clinical skills that they must acquire and the professionalism that they must demonstrate. Noteworthy is the fact that professionalism, as outlined in the AOA Code of Ethics, addresses explicit bias, and it's framed as discrimination, which is already illegal. But they They only address explicit bias without any mention of implicit and systemic bias, which contributes so greatly to minority health disparities.
Hi, baby. I love you.
Medical education has an obligation. The first obligation is to prepare the students to meet the future healthcare needs, and those needs are growing exponentially. They have the responsibility and obligation to change in order to decrease systemic bias in the medical education organizational design, to promote and model anti-racist culture, and to do that by looking at all of the policies and procedures that we have in place to deliver on our responsibilities. I also would suggest that we carefully look at how we use the MCAT for admission purposes. We will need to modify the curriculum to promote an understanding and appreciation of population health and the etiology of minority health disparities for the future competent practice of medicine. We've got to drill down into that. We have to recognize and commit to educating competent physicians who must be capable of appreciating the role of implicit bias in compromising the quality of healthcare and recognizing implicit bias in him or herself and in his or her peers and colleagues. This will also require faculty and staff development. An important thing what we need to do is reframe inclusion. Reframe inclusion to be a two-way process that supports appreciation for and practice of cultural humility. And to do that through purposeful, multicultural, clinical immersion experiences for all students. And this has to have clearly defined learning objectives related to social determinants of health connected to it. So now, let me talk about next steps. The healthcare workforce has an important role as a pivotal participant in a system that produces minority health disparities. You are responsible for and expected to create the competent physician workforce for the future. My charge for you is own your piece of the solution as medical educators and researchers. It is your obligation to address systematically and systemically the challenges of education to meet the needs of the populations of the future. And before I close, let me tell you, I'm reminded of something that Peter Dane, who was my assistant dean for curriculum, told me one time. And because we were trying to change the curriculum, everybody was just doing little bits of tweaking. And there's always a tendency to just want to tweak what we already do. And to quote him, if it ain't broke, break it and start to fix it in the way that we would like for it to be, not just try to change it into what we can accomplish. Let's aim for the skies. So you have the option in the current environment and an environment that clearly will persist for years. You have the opportunity to make change. So own your piece of the solution as medical educators. Thank you so much for inviting me to speak.
Thank you, Dr. Ross Lee. We really appreciate your words of wisdom, and we will accept the challenge. At this time, what we'd like to do is open the floor for questions. You can post them through your chat, and we'll wait and see what comes up.
Does that mean no questions?
We
there'll be questions.
There'll be questions.
I do have a question. We have some significant challenges today as an institution addressing not only the health needs, but with our new clinical psychology program, the behavioral health challenges as well. And we're trying, but we're challenged to have an impact on the underrepresented minority communities that surround us. And certainly behavioral health is just as challenging as general physical health. I was wondering if you could comment on that, Barbara.
And given the times and the need for human beings, as I heard today, to be more social, the mental health challenges this creates, I think it's just going to mushroom. And it is really important when we talk about changes to meet the future, that behavioral health has to be a prominent part of that. This is a new world, folks. We cannot continue to think we'll be successful in delivering on our responsibilities by continuing to do the same. We've got to be able to look around corners. Even the whole clinical training piece, hospitals are in trouble. They are in real trouble. And for our profession that depends so heavily on the small and medium-sized hospitals for training our students, we've got challenges, and they're not going to get better, they're going to get worse. And most of what we can do, we can look internally and see kind of the things we're responding to, like, accreditation requirements and licensure board exams. But we've got to be able to engage those external units as well to say, hey, you've got to change. You can't hold us to a standard that doesn't help us meet the future.
And we are feeling the pressures, especially around our Kansas City campus right now, with the increasing amount of COVID-19 in the community, especially communities of color. There are increasing race and equity issues that are front and center right now. They've always been there. We just have looked past them. Now there's a degree of civil unrest, and all of this comes together to impact communities of color. And our original campus sits right in the middle of a very diverse part of town. And we're starting to feel this. And, we're also concerned that, whatever happens on November 3rd, November 4th is not going to be a good day. This all comes together on the health and well-being of the community.
Yeah.
But I know that we're not unique. Kansas City is not unique. Are you seeing any best practices from any of the cities around this country that we should advocate for within our Kansas City community?
Yeah, I think everybody's struggling, trying to better position themselves to be able to respond in a positive manner to what is occurring and what we anticipate may occur. Because as much as we talk about social injustice and economic instability and minority disparities, we're also going to have to add onto that violence, because we are becoming increasingly violent. And we have to have a strategic plan as to how we address that in the places where we are. Because one of the things I've admired about Kansas City is you weren't just positioned in a community, you made yourself a part of the communities where you are. And that's for planning going forward. You have already built a level of community comfort and support that will be necessary in the future. And boy, who can predict the future? The other side of this is not going to look like this side. It's going to be different, folks. So we've got to put our thinking hats on here and be positioned, because we do have a critical responsibility as it relates to the circumstances that are occurring.
Thank you, Dr. Rosalie. We do have some questions starting to come in. I'm going to ask everybody who asks a question to please be brief. Dr. Paulson, I see your hand up, and then I'm going to go to a question that was in the chat by Dr. Was it Randolph? So Dr. Paulson, go ahead.
I see that smile on Dr. Ross's face. I had the opportunity to participate in the Osteopathic Health Policy Fellowship, and for lack of a better word, she has busted my chops on a couple of occasions. I think for this group, I would really like to hear you talk about, you titled this High Ground, and for health policy folks, that makes sense. But can you share with this group the difference of stakeholder versus high ground, maybe at a higher level, so that the other people that aren't familiar with those terms might?
Well, a stakeholder fundamentally means that you have a stake in what's happening, okay? But if your strategy is to only guard that stake and not look at where that stake falls, that stake falls in the bigger picture, you're not going to be successful, and you're not going to influence the direction of change. So in the fellowship program, we forced the fellows to get to the high ground, you know? Anecdotes are not acceptable. We don't allow them to use the word but, yes, but. You know? The issue is, let's look at the big picture and then see where we're positioned as that high ground. What is it we want to achieve? And how do we get there from where we are? That high ground, and not just protect what they already have or where they already are. Does that help?
Thank you. I'm going to go to the next question. What are the best and most creative efforts you have seen regarding underrepresented students and faculty among any med schools, DEO, or MD?
The problem begins as a pipeline. And that is the pivotal issue, is that pipeline. We are required to follow external requirements of accreditation, etc. But we set our own standards using those external accreditation requirements. And I have seen medical schools be reluctant to not compete against each other versus focusing on their commitment to the populations we serve. In other words, they don't get to the high ground. Now, the places that I've been where they have a much more diverse population of students are the institutions that have made the commitment to diversity as a power tool, as a strategy for excellence. And they have built significant systems around the student population to promote an anti-racist environment. Now, right now, I think the best performer, and I say that having been the dean of 2 or 3 schools, the best performer that I've seen in that regard is the New Jersey school, Rowan School of Osteopathic Medicine. That's the best osteopathic school that I've seen thus far. Now, Harvard has some wonderful programs as well, by the way. Of course, they suck up all of the high-ranking minority students in order to promote that diversity. So I discount what they're doing. But what I can tell you is, if the institution makes the commitment, the students at that institution, and when I say the institution, that means everybody in the institution makes the commitment to diversity as being a tool for excellence. If that commitment is there, the students will be proud to be in your institution. The students will be proud. And if the students are proud, you can't lose. You've got to develop a pride in the direction that you want to take. It's great if it's in the faculty and staff, but the most important place is in the students. If the students are proud of what you're doing because you've made that commitment, hey, the world is yours.
Beautiful. I have another question. It says, how can technology help physicians address healthcare disparity?
I think medicine, and this is an area that for scholarly work, I think medicine has been very slow in adapting and adopting technology to those things that we do or need to do. Technology can monitor your patients, whether it's blood pressure on a regular basis, and they can signal you. There's much more capability and capacity than just telehealth, okay? The patient can be better linked to you so that you know when there's a need. It provides a basis for you to do much earlier interventions and to better track chronic diseases, you know? So I think medicine's got to get on the ball and look at ways, and particularly medical education, that we can use technology much more effectively. Now, I used to use the motto, high tech, high touch. We are a high touch profession. And we have to also approach that head on. What does that mean as an osteopathic physician? Okay, and we also know from studies, by the way, that came out of Wayne State University, that patients who are touched in that doctor-patient interaction are much more satisfied, much more compliant, and think that the doctor has spent all the time in the world with them just because the doctor touched them. So there are things, technology is the new frontier, and here's an opportunity to get there.
Thank you. Dr. J.
Dr. Lee, Dr. Ross Lee, first of all, I want to say welcome back to Kansas City University. So glad to have you here.
The room looks different, but yes.
It is, yes. In light of the civil unrest, in light of social injustice, what advice would you give to an underrepresented minority student on our campuses attending medical school? What advice would you give?
Okay, let me speak to you candidly. This social unrest and the George Floyd is so personal to Black people. It is a personal, emotional reaction. And we all want to do something. So from the medical student perspective, I think we have to allow them to do something, an outlet that's positive both for them, for the communities they're concerned about, and for the institution. So capture that emotion into a proactive plan that makes them better and makes all of us better. Because that frustration of not being, that's why I'm doing all of these, by the way, virtual talks. You want to do something. It is, I can't even begin to tell you how personal this is, you know? And it's scary for a Black person, what's going on in this nation. It's very scary.
Dr. Ross, this is Robert White. I really appreciate your statement about having a pipeline, and I wanted to share with you that at Kansas City University in the College of Biosciences, we have a Master of Science in Biomedical Sciences program students can use as a springboard to go on to medical school. And it's a rather large program, about 120 students. And I want you to know that typically 15 to 20% of those students are minority students. And this is a pipeline for the students to go on, not only to our medical school, but to other medical schools.
Yes.
So we are having an impact in the communities we serve. And in addition to our one-year track for going on to medical school, there is a research track we have, because not everybody wants to be a physician.
Yeah.
We have students who want to go on for their PhD. And out of the students who graduated from the 2-year research track, 60% of them were underrepresented minority students who wanted to go on for a PhD. So we actually have 2 pipelines in essence. So I want to just share with you, I really appreciate your statement about having a pipeline, and we are trying to do that at KCU.
And let me tell you too, just to add to that, we've got to start reaching out and touching minority students earlier. Do you know how intimidated they are by talking about medicine? And there's no need for them to be. I think about the people that I went to school with, many of whom were much brighter than me and had greater resources to be able to go to medical school. But they were so intimidated, and we do that. And we can stop that just by, and in fact, in New York, use them to reach out to these students and be human, to show them that it can make. And it doesn't have to be, you know, Black on Black or Latino on Latino. It just needs to be a medical student reaching out. They don't have to spend time, they don't have to be big brothers. Just reach out to these students. Provide them with a sense of value. And that's what we take away from minority students in the educational continuum.
Thank you. Dr. D'Agostino.
Yeah, thank you. Great talk, and thank you so much for your answers. What a wonderful influence, and giving us such knowledge. You know, your experience is really amazing. I wanted to talk about, I actually have 2 things that I wanted to talk about, but I think the most important, you had mentioned while you were talking the MCAT. And the MCAT has been a challenge for many of us, as are other standardized tests that have biases automatically built into them, and language that has historical value but has no place in the modern day physician practice. And while we have pathway programs to enter our medical school, that in some cases we actually waive the MCAT so that we can, because we know what the students are doing, that we can help them get in easier and faster. We're not doing that across the board nationally. I'm not a big fan of it as a leveler, because I don't think it adequately represents all students that are trying to apply, but nonetheless, it's part of the system. And I was wondering if you could get a little bit more in depth about that, and how at the level of testing and barrier exams, we can do a better job to help all students, but especially those that aren't being given the chance to get through because of these barriers.
Let me first start with the MCAT, and then I'll make a comment about the COMLEX. But let's first start with the MCAT. We use a tool. First of all, the MCAT is supposed to tell us how prepared a medical student is to go to medical school. It just tells us the level of preparation. That's all it's supposed to tell us, okay? But what we've allowed the MCATs to do is to structure a competition. Now, the reality is, if you ask, and I've talked to many of the major allopathic institutions, the first thing they tell you is, we would admit more minorities, but we can't find any qualified minorities. I want you all to know, and you have already expressed it, there's a difference between being competitive and being qualified. And when you turn a student down because he's not competitive, and you tell him, her, that she or he is not qualified, you've done more damage than you know, okay? The issue is, and I had post-bac programs, pre-matriculation programs, high school programs when I was at Michigan State. And this is old MCATs. And what I learned in watching the MCATs gives you information, not just numbers. It gives you information about that student. But all we look at, by and large, are the numbers. What I found when looking at the MCAT, and these were several iterations ago, if the student had an acceptable level of science background, okay, and their reading score was high, they could succeed in medical school. But if a student had, let's say, average, a low reading score, they could not be successful in medical school. Now, the current MCAT has a reading section in there. I would suggest you all look at that. For years, I only used the reading score to determine whether or not, because we had been exposed to the student, either in a post-bac program or a pre-matriculation program, whether or not, if they could read, and by the way, you can hire people to teach, and it's not that they can't read. Medicine, there's such a volume of information that students have to absorb. So they have to be able to read large quantities relatively quickly with comprehension. And that's where many of our students fail, particularly the minority students. But you can teach reading for speed and comprehension. That's something that we can do. But the student has already been marginalized in the system before we get to that point. So yes, then the other side of the MCAT is, then we start competing with each other as schools for who has the highest MCAT students. What is that? Why, it's such a disincentive to achieving our objectives that I can't even begin to believe it, And it's a one-day test, folks, come on, okay. So having said that, the other concern I've had, although things are changing as it relates to COMLEX and USMLE, changes in the air. But why, and I challenged this at ACOM, why a medical school would allow an external body to tell you whether or not a student is qualified to graduate when you are the teachers, you develop the curriculum, you collected the tuition, and you pass them in their courses. But you're going to let an external body tell you whether or not that student can graduate? I find that so offensive, I can't even believe. Having said that, however, yes, I think the students need to pass COMLEX too, but they need to do it prior to admission to a residency program. That should not prevent them from getting their degree. They paid for it, they spent time getting it, and so I have a real concern about how we use standardized exams. In fact, I think we abuse the privilege of being able to evaluate and assess students when we use standardized exams after we have been the ones who've done the education. It's just terrible.
Thank you.
Don't tell them I said that, by the way. It's a secret.
It's, thank you for that answer. I can tell you that there is some good coming out of this COVID crisis, though, that every dean is getting together weekly. For the last 6 months, we've been doing that. Now it's every other week. And these conversations are coming up for the first time in my career in the last 30 years in a way that's actually, I think, going to help move the needle. So I appreciate your insight. Thank you.
I'm going to try to get about 3 more questions in. And sorry that we're not going to be able to get everybody's question. The next question is, I just became aware of the president's executive order prohibiting federal offices, agencies, and subcontractors extending to institutions funded by federal grants from conducting diversity inclusion training. What impact will that have in training and educating our future physicians?
Yeah, I think we better read the executive order, and here's another strategy I always follow. Learn the rules, know the rules in detail, understand the order and what he's saying, and if you know the rules, you can figure a way to get around that. I don't care what he says. Ultimately, you can figure a way around that. Just read the rules. Whatever that executive order is, I promise you, there is a way that you can accomplish what you need to accomplish. You're gonna need to be innovative, but you can do that.
Okay, the next question. In a curriculum that already seems overfilled in years 1 and 2, are you in favor of increasing the length of time for medical school, or would you like to see public health emphasis in perhaps year 4? So restating ideas of how to better do what you do while still doing more.
Okay. Number one, I think we have to get out of the box of putting our students in first and second year, third and fourth year. That ultimately there's a better way to build an educational continuum. Okay. Personally, I find the concept of audition rotations to be a little bit offensive. You've got time in the curriculum. You just need to not put what you need in the curriculum in a box. That tear down some of those walls, okay? And actually, now that we're using technology, the time that the students probably need more education on population health is when they're doing, while they're completing their third and fourth years, because that's when they're seeing the people. So let's be creative. Let's get out of the box as to what we put when and where and how, you know?
Thank you. And this will be the last question. What is your advice regarding training medical students to prepare them for the types of physicians we need for tomorrow? Could you delineate specific actions we can take? I think it's, yeah.
The one thing we know about tomorrow is that it's not going to be the same as today. And the one failing that medical education has had since Flexner is training physicians for the future based on what's being done today, as opposed to coming up with some of the conceptual fundamental skills that no matter what happens in the external environment. There are some things we know that are occurring, and they're occurring in society, but isn't it important for us then to figure out what that impact would be on healthcare? And that's kind of what the presentation was today. Things are changing, you know? Yeah. We can do more if we allow the students to provide some of the lead in how they accomplish our goals related to content knowledge and clinical skills. Because I think we do have the time. We're finding out right now we do. Actually, I'm afraid that we're going to overload the students at home on their Zoom, you know, because now we don't even have to look at a 50-minute lecture hour. We can just keep pouring stuff and pouring stuff. I think we just have to take a step back and figure out what we want to accomplish and create more than one way of getting there, you know.
Thank you. Thank you so much. We very much appreciate you spending time with us. I'm going to turn it back over to Dr. Hahn for some closing remarks. But again, I want to thank you, and you are special. Thank you very much.
Yep, that's for sure. Thanks, Dr. Durgans and Barbara. Thank you for coming to visit again. Once we're through this pandemic, we're going to get you back to campus again. Maybe bring you down to our Joplin campus. But over the last 25 years, you've been a great mentor, colleague, and friend, and I appreciate that. And actually, when I first started at Kansas City University, you sent me an orchid, and since I'm at home right now, this is it now, almost 8 years later. So it looks great. And Barbara, thank you. Thank you for everything you do.
Wonderful. Oh, that's great. I so appreciate the opportunity to talk to you all. And I know, given the kind of people you have and the kind of institution you have, that you all are not comfortable just doing the same old. And I expect you'll rise to the occasion and, in fact, model some wonderful things for the rest of our osteopathic college colleagues. How's that? You know?
Well, thank you so much. We're blessed with a fantastic team of faculty and staff and superb students. And with that, we hope to make a difference. And thank you for your guidance.
I thank you.
Barbara, take care. Take care. Thanks,
you.
everybody. Bye-bye.
Thank you all. I really appreciate you spending the time. Even if you're at home, it's time. The days are getting long. Bye-bye.